I want to welcome all of you here to our Health as a Civil Right program. Today is session 2, and we'll be talking about policy and racial health disparities. A few minor housekeeping items. I know when you all came in, you were on mute. It would be really helpful if everyone stays on mute so that we don't have too much interference when our speakers are answering our questions and telling us about the topic today. There will be time for question and answer at the end of the program. You can post your questions in the chat room and I'll be taking note of those so that hopefully we get to everyone's question. Know that the program is being recorded, and after the program, recordings and slides from the series will be available on our website, www.sankofacollaborative.com. Well, yes, thank you, Sam, for reminding me. Please make time for the third and final session of this program, Community Responses to Racial Health Disparities. That will be held next Thursday, March 18th from 1 p.m. to 2:30. And you can see our list of speakers there. I'd like to introduce our Linda Epps. I don't know if you're moderator today, and that's why I'm stumbling a little bit, but Dr. Linda Epps is a founding member of the Sankofa Collaborative. She has more than 45 years of experience working with educational and cultural institutions, including the New Jersey Historical Society, the New Jersey Network Television and Radio, and she had various positions at Bloomfield College, where she worked for 27 years. And I have to mention that that's where I met Linda many years ago. And I can honestly say that has been the best takeaway of my years at Bloomfield College, was bringing Linda along with me. And we've been through thick and thin. So I'm very happy to introduce her. Linda, in 2011, formed 1804 Consultants. She works with history and cultural institutions within New Jersey and nationally, and these have included the Smithsonian National Museum of African American History and Culture, the William Trent House, the Newark Public Library, the Scotch Plains Public Library, Old First Church of Elizabeth, New Jersey, and the Timbuktu Historical Site. So without further ado, Linda, I turn it over to you.
Thank you, Michelle. And so we have a mutual admiration thing going too, because it's been a pleasure working with you in various institutions for, I guess, about 25 years now. I can't believe it.
Actually, no, more. My Charlie just turned 27. He'll be.
And I knew you before Charlie.
Yes,
30 years.
Yeah, I know, it's crazy, and we don't look a day older.
I don't know how it could be 30 years when I'm only 32 myself.
Exactly.
So, but on to business. So I'd like to welcome all of those of you who might be attending their very first Sankofa Collaborative program, and to welcome back those of you who have been regular attendees to our programs, which we've now been producing since 2017. So we're getting a little history under our belt. Most of the time, well, all of the time before COVID, our programs were held at Grounds for Sculpture. And I should mention that the Sankofa Collaborative is a group comprised of 5 institutions, 1804 Consultants, as Michelle mentioned, the William Trent House, the Stroudsburg-Sauerland African American Museum, the New Jersey Historical Society, and Grounds for Sculpture. We take our name, Sankofa Collaborative, from the Twi language of Ghana, which roughly translates into go back and get it. It's often depicted by a bird, as you can see in our logo, with its body facing forward and its head turned back, holding a precious egg. And this and other Sankofa symbols remind us of the importance of learning from the past. And that's just what the Sankofa Collaborative is. We were quiet during the early stages of the pandemic, and our fans, some of you out there, were asking, where are you? Aren't you providing anything virtually like everyone else? So we decided to join the bandwagon, and this is our second in this health series and our second virtual production here. So those of you, I'd like to give thanks to our supporters today. Our supporters forever are the New Jersey Historical Society, the New Jersey Historical Commission, the New Jersey Council for the Humanities. This particular session is sponsored by the Robert Wood Johnson Foundation with additional funding provided by Patient First. And we like to give thanks to them. We are a not-for-profit institution and we depend on donations, and not only from large corporations or large entities, but we can stand a few checks from our public as well. So if you're ever have a few dollars to spare, please think of us. I started off my remarks last week with a quote from Reverend Martin Luther King, who addressed the Medical Committee for Human Rights of the American Medical Association in 1966. And he said then, of all the inequalities that exist, the injustice in healthcare is the most shocking and inhumane. So confrontation with illness, as I know from personal experience, and I'm sure many of you do too, is stressful in itself. But adding concern about affordability and quality of treatment adds greatly to that stress. I have, and I'm sure some of you also have, those memories from childhood that stay with us for decades after their occurrence. And I can recall such a moment when I was having a conversation with a friend during the height of the debate about President Barack Obama's affordable health care proposal. And this friend was trying to come to grips with her position on universal health care and asked me about my feelings on the subject. So immediately my mind went back to times growing up when illness would strike and seeing my parents at the kitchen table going over their meager finances, trying to fit a doctor's visit or two into their budget for that month. So I replied to this friend rather quickly. I've lived with health insurance and I've lived without health insurance. And without it, I know life is far better when one has the ability to seek treatment when illness strikes and to have the confidence in knowing that the healthcare one receives is not compromised because of inability to pay and ineligibility for healthcare because the price the person cannot afford health insurance. So as Michelle mentioned, this is part 2 of our series on health as a civil right. And today our focus is on policy and racial health disparities. And serving today as our moderator is Ms. Karen Clark, who is President and Chief Operating Officer of Health Horizon Blue Cross and Blue Shield of New Jersey. Hope I got all that right. It is the largest managed healthcare company serving the publicly insured. Ms. Clark has served as terms as board chairperson for the Medicaid Health Plans of America and as a board member of the Association of Community Affiliated Health Plans. And under her leadership, we're very, very fortunate to have her. This is long, so just hold on to your seat. Under her leadership at HNJH, millions of Medicaid recipients received access to quality health care and support for necessary services. The company also received accreditation from the National Committee for Quality Assurance and several recognitions of top performance for high quality health care. And it grew to be one of the largest Medicaid plans in the country and received national recognition for innovative community outreach programs. The company also successfully implemented a program for Medicaid expansion under the Accountable Care Act. Prior to her time with Horizon VCBS, Ms. Clark first found a home for her passion to serve the underserved as president and board chairperson for AmeriChoice of New York and New Jersey, which is now United Healthcare. She also held management positions at Travelers Corporation, Managed Healthcare, and Whitaker Health Services, as well as health insurance plans, HIP of New York, and Lassiter and Company Healthcare Consulting Firm in Washington, D.C. She served on various policy setting boards and committees, including the New Jersey Managed Long-Term Services and Support Planning Committee to service the aged and the disabled. She has been recognized with several awards, including being named one of the top 15 minority health executives in the nation. Top 15 in the nation by Modern Healthcare and Professional Women of the Year by the National Association of Professional Women. And since her retirement a few years ago, but I know well that people like Karen don't really retire, she continues serving her community through her work as a chaplain at the New Hope Church of God in Trenton. And her goal is to continue to advocate for innovation in private-public partnerships to address cost, quality, and access to healthcare in the United States. She obtained her MBA in Marketing and Finance from Columbia University. She also attended Boston University and received her bachelor's from our own Rider University. So I welcome Karen, and she will introduce the other members of this panel. As last week, we've got a very, very distinguished and articulate group of people to speak with you this afternoon. So go ahead, Karen, and thank you for coming.
Thank you, Linda. Wow, after hearing that, I feel tired, and I'm so glad I'm retired so I can take a nap.
Right.
That's the one good thing about being retired. You can
Yeah.
take a nap. Well, welcome again to this session on the impact of policy on healthcare disparities. This is a broad topic with many facets, and today we're going to tackle it from the experiences and perspectives of our panelists. Thank you again to all of our panelists. It's important that Sankofa is addressing the issue of healthcare disparities through the lens of policy. Dana Bowen Matthews, some of you may know her, pointed out the importance of the topic. She's the author of Just Medicine, A Cure for Racial Inequality in American Healthcare. And I like her quote. It gets to the raw, straight truth of this. Dana said, "What we politely call a health disparity is killing people of color daily. It is causing people of color to live sicker and die quicker because of the color of their skin." And you could add in there any other group that is experiencing such disparities. This is indeed important stuff. And at the core, it's about quality of life and saving lives. We should note that healthcare is not only one of the most complex systems, but is also one of the most regulated areas of our society. So policy, laws, and regulations matter. Very importantly, healthcare policies determine what programs are funded and who in the system can get paid, and often how much they can get paid. And several of our panelists are very well versed in these policy areas. So for the sake of today, let's include under that policy umbrella laws and regulations, and perhaps some will even wander into the unofficial practices and policies. So I was interested to hear, as I listened to the last panel on March the 4th, that many believe that these disparities are not just a result of current day policies, but of past policies dating back to slavery, segregation, Jim Crow, and other institutions in this country. I remember a quote from a former Surgeon General, and based on some of the comments about how long folks have known each other, I think you'll remember Dr. Jocelyn Elders. And she was given to making fiery quotes. Here's one that I like. She was talking about pregnant teenagers, but she said, "Teenage mothers are captive to a slavery the 13th Amendment did not anticipate." And I would argue that that quote could be applied elsewhere in our healthcare system. Perhaps we've not taken in account the long-term impact of systemic racism, policies, and laws on the health of individuals. So healthcare disparities is not at all a new topic, though many have become newly aware of it. And that's mainly because of COVID-19, which has highlighted and exposed the existence of healthcare disparities and brought them to our attention mainly through the media. And we have a panelist who is going to address us from the viewpoint of the media today. Evidence of these disparities in the United States has been growing in areas of healthcare access, health coverage, and health outcomes. This is not new. Differences based on race and ethnicity and other components continue to show in the data for African Americans, Hispanics, Native Americans, Pacific Islanders, and others. Now, when I was considering this panel and the topic, I actually thought back to 1998. I think a number of you will remember Dr. David Satcher was in the role of Surgeon General then, and he was also a previous director of CDC. And I remember the kind of hope and excitement that I had when I saw that he was putting a lot of focus and emphasis on healthcare disparities. And in fact, in early 2000, I believe, the legislation was actually passed that set up the National Center for Minority Health and Health Disparities. And there were a lot of initiatives and a lot of talk about healthcare disparities then, and some of those initiatives had some individual success. And yet we sit here about 21 years later, and these disparities still exist, and we're still having these discussions. This is a big issue that needs to be addressed more widely and with more intentionality. Thank you, Sankofa, for your efforts. Now, on the positive side, the U.S. Department of Health and Human Services has implemented programs and policies to eliminate racial and ethnic disparities, as have local and state governments, including the state of New Jersey. They're also broadening these programs so that they're considering things like social determinants, and we have at least one panelist who will likely speak about social determinants in healthcare. Yet the disparities continue to exist, and in some areas, the gaps are widening. What can we do, and what are we doing about policies to change this trajectory? We're going to inform and enlighten you today. And then as a final point, you may see healthcare disparities as a civil rights issue and an equality issue, and I believe they are, but you may be surprised to know that it's also a cost issue. The Kaiser Foundation has estimated that healthcare disparities amount to approximately, now hear this, amount to approximately 93 billion with a B in excess medical care costs and 42 billion in lost productivity per year, as well as the economic losses due to premature deaths. Think of the care that we could provide with that kind of money, while we would be improving the quality of life for Americans and saving the lives of many. So let's get going. This is truly important stuff. I'm going to go ahead and introduce our panel, and they will each present, and then you're going to have the opportunity to ask questions at the end. Just put your questions in the chat room and our facilitator will gather them. So let's begin. I believe first up is Brittany. Brittany Holman-Trundy, PhD. Dr. Brittany L. Holman-Trundy is a senior policy analyst at the New Jersey Policy Perspective, a non-partisan think tank that works to make policy change, advocating social justice through independent research, analysis, and strategic communications. She researches and speaks on healthcare system reform, the differential impact of health policies, and the role of social and cultural factors in healthcare access and health outcomes. In October 2020, NJPP issued Unprecedented and Unequal Racial Equalities in the COVID-19 Pandemic, a report authored by Dr. Holman-Trundy. Prior to joining NJPP in May 2020, she taught at the Princeton School of Public and International Affairs at Princeton University and in the Department of Political Science at the College of New Jersey. Dr. Holman-Trundy received her PhD in politics from Princeton University in 2018. We're so pleased to have you. Thank you.
Thank you so much. Yeah, and I'm going to share my screen. I have a PowerPoint. Hold on, it'll take a second here. But I just wanted to kind of give a very brief just statement on NJPP and kind of what we do and how it's going to come into my discussion here. In that New Jersey Policy Perspective, we're a think tank and we do research, but we also and we're focusing a lot on tax and budget and how policies are actually designed and the funding and such, and how that impacts the outcomes. But we think of ourselves as a think and do tank, in that we testify in the legislature and we meet with decision makers and really work hard to communicate our research findings, not just produce them and put them out there, but also communicate them in a clear way to decision makers, the media, and the public. So that's something that we're pretty proud of. Okay, so let me just kind of dive into what I am covering today. I think some of our other panelists will be focusing a little bit more on maybe the healthcare specific side of things. I'm sure we'll all talk about a variety of things, but I wanted to really dive into what I started to mention last week, which is the social determinants of health. And so, as was mentioned, medical care policies, such as the availability of health insurance coverage, the way that hospitals are funded, and training programs are funded, the way the state funds charity care, which is helps to cover the costs of caring for uninsured folks, these are often the first things considered when thinking about health. But that's, of course, not the only thing affecting the outcomes that we're seeing. And so beyond medical care and health coverage specifically, as I mentioned last week, there are many aspects of life that policies are exacerbating or helping to lessen racial health disparities. And these can include occupation, education, housing, food security, transportation, and even there's been research more recently on kind of the psychological impacts, the long-term impacts of structural racism, which they call weathering, and how that affects stress and health outcomes. So the way beyond the different types of policies, issue areas, NJPP and our research also focuses in on the way that different characteristics of policies can impact these disparities, even in seemingly race-neutral policies. So there are a few different things that can happen. It can be about the funding, as was mentioned. That can include like underfunding certain programs that are widely used by communities of color, taxation policies that disproportionately impact particular groups, or the ways that, for instance, Medicaid reimbursement rates and things like that can very much limit the incentives to provide care to certain groups on the ground. The design of the policy, so like programs such as eligibility limits, application barriers, so technology, we've seen a lot of that with the COVID vaccine system, and that it seems like the internet is a great thing, everyone can access this, but actually not everyone has equal access to the online sites and such, and so we've seen that play out on the ground. Geographic limitations and how they're actually where they're covering and things like that are part of the design of a policy and how it's planned out. Implementation, of course, I think we'll hear more about that on the ground, that how outreach occurs, how difficult it is to get to things. We saw this with some of the COVID testing, initially the sites that were established maybe didn't reach people because you had to drive to them and things like that, and people who didn't have cars couldn't get to them. So access to services is a big part of implementation. And then data collection. We've been working on this a little bit more at NJPP more recently in terms of how the state and decision makers are actually collecting data to understand the impact. So how they're defining different racial and ethnic groups, the questions that they have in surveys that they do about particular topics, maybe things they're leaving out. The way that surveys and data collection is designed can in and of itself prolong racism in policies. So that's another aspect that is often left out. So today I just want to kind of run through how, very briefly, how policies that are maybe not as obvious, not as obviously connected to health, can actually impact health, our disparities in the long run. Oh, good, it came up quickly. When I was practicing, this picture is very detailed, so it was coming up very slowly. So the first one that I think a lot of people have heard about now in recent years has been the impact that housing policies can have on health outcomes in the long term. So redlining is often referred to, and this is a map of one of those old redlining maps where they gave grades to different neighborhoods. And this was a policy in the 1930s to up to officially 1968, the Fair Housing Act, where they actually after that, there were continued policies that affected this, but officially discrimination was outlawed at that time. I'm going to talk more about that, but they basically, the way this worked was that they would give grades to neighborhoods, and they limited the home loans that were seen as risky to certain neighborhoods, and these were largely Black neighborhoods, Hispanic, Latinx, and immigrant neighborhoods. And so this limited the wealth building, because a lot of people in the US gain wealth over time through the equity that they have in their homes. So this limited the wealth building. It also pushed, as I'll show in a second, I'll discuss in a second, it pushed Black Americans in particular into public housing units. As white Americans were moving out to the suburbs, Black Americans were being kind of directed into these public housing units through these types of policies, which in turn, I'll talk about environmental policies. These units were in areas that had higher health hazards. Reports continue today of lower appraisal values, additionally, for Black communities, for houses, higher property tax assessments. So the way that wealth is taxed and assigned essentially through appraisal values are still to this day continuing some segregation in these areas and continuing to kind of prolong these effects. So how does that then impact health? Well, if redlining limited the housing options and the wealth options, value options for Black Americans, this in turn led to, as I mentioned, pushing Black Americans toward public housing. As white families moved away from cities, there was greater segregation, or continued segregation and harshened segregation of neighborhoods and schooling, and reduced wealth. In turn, over time, that developed into a system where there was a lack of resources for future housing. If you don't have equity and you're not able to build wealth, you're going to have less available funds for improving your housing, for medical care, and other bills. Additionally, lack of investment in these areas, in like public housing areas, the surrounding areas, limited the resources available to many of these communities. So high quality hospitals, and I already mentioned the schools, stores, etc., where food deserts are the result of this type of issue. And so essentially investment tended to follow wealth, and in turn, not only was the housing more limited, but it was creating challenges to health outcomes just through everyday living for folks. In turn, this results in, again, as wealth is not built, a need for families struggling with bills to live in multi-generational households, which, as we've seen in COVID, is a high risk if you have elderly and children living together in one household. Limited ability to access preventative care, which affects long-term health outcomes, particularly children living in poverty. This is a huge defining aspect of someone's long-term health. Inability to pay medical debt, which is more likely that there's going to be medical debt due to higher uninsured rates. As I already mentioned, limited resources for nutritious food, which is crucial, especially for children. And then segregated schooling, limited educational opportunities that in turn, we've seen many health economic studies show that education impacts long-term health outcomes due to information and various ability to gain a higher paying job and things like that. So this simple, seemingly, housing policy leads to all of these very long-term impacts on lifestyle, on resources, and on health. Environmental policies, some similar things. Again, I'm kind of running through this very briefly, but Superfund sites, as in the same kind of era as during and post Great Depression, as industry was moving out of the cities, there were a lot of these industrial areas that are very hazardous to health that were left and kind of abandoned and developed, and housing units were developed near them or on them. And they've done studies recently that show that these are called Superfund sites. The ones that there are different ones: Superfund sites, brownfields. Superfund sites are required, are part of a federal list that they need to be addressed, and there's some funding for that. But there's been recent studies where like 70% of Superfund sites are within a mile of public housing, because that's the way it developed. And you can see in this map that New Jersey in particular has a lot of both housing projects and Superfund sites. It's hard to see. I couldn't find a map just of New Jersey with this, but it's very concentrated here. And these affordable housing units, as I already mentioned, Black Americans were pushed, and immigrant populations were pushed toward these units, and were often tied to the unit through rental policies, through the way that that funding and help was provided. They were tied to the units, and so they weren't allowed to leave, even though it was hazardous, or they had very limited options to leave. So they were forced to live with health hazards. They also tended to live in older homes because they couldn't buy newer ones, and older homes are going to be more at risk for things like lead exposure, lead pipes, lead paint, and things like that. Things that wealthier neighborhoods might be able to address or build new homes. Black Americans, immigrant populations, end up living in these older neighborhoods where it costs more, because it costs more to address these things because they haven't been addressed so far. And this leads to, again, this is a map. I couldn't get one of just New Jersey, but where you can see they have a graph here of the intersection of populations of color and drinking water violations. And so the darkest here is where there's a very diverse population with a high number of drinking water violations due to these health hazards. And you can see that New Jersey in particular is, again, struggles with this, as do some other areas of the country. And I have all the resources on the slides here if you want to go see them. This segregation also, affects how people are affected by air pollution, which is a big thing with COVID. And our air pollution patterns around here have been closely tied to the development of those two major metro areas, NYC and Philadelphia. And so as this housing segregation happened, as the options to leave those areas were limited, it just, the health hazards piled on essentially over time. And this is just an example NASA had of this. It was before COVID. During COVID, it lightened up a bit, but we can see that this area up here, which was highly hit by COVID very, very hard because of the way that the virus spread, is also a higher risk for air pollution as well. This in other policy impacts, and I'm going to try to keep it as brief as I can here. Other policy impacts, it's not just housing and environmental. That's just two examples of the way that policies can impact long-term health outcomes. And it's not just limited to metro areas. So a couple of other examples in New Jersey is that, the Temporary Assistance for Needy Families program involved a family cap for quite some time. So this was a policy that denied extra resources for parents on TANF for any additional babies born during participation in the program. So generally you're given a certain amount per child and such. And they had this policy that said, nope, if you have a child after like a few months in the program, we're not going to give you the amount that we would have given that child if you had come into the program with that child. So families on TANF, who were largely communities of color, were given limited resources and not allowed, the policies tried to force folks to not develop their families or limit the resources for their families. New Jersey was the first state to implement this in 1992, and it was only recently, just this last year, permanently repealed. And other policies within programs like that, like work hour requirements, such as that mean that you have to work a certain number of hours to remain in the program and get that help. it limits what parents can do, and it ends up disproportionately impacting communities of color who are disproportionately represented in those programs. Additionally, tax policies, the way that taxes are structured can redistribute wealth in such a way that it disproportionately hurts communities of color and limits their ability, again, to pay bills, and it leads to these long-term health challenges in paying medical bills and getting insured, and protecting oneself from health hazards. Things like sin taxes, that focus on deterring particular health behaviors such as cigarette smoking, alcohol drinking. So these are taxes, excise taxes on alcohol, cigarettes, and such, have been shown to, especially cigarette taxes, disproportionately impact Black communities due to the history of the tobacco industry targeting the targeting they did in their marketing for like menthol cigarettes and such. And there's a great book coming out by Keith Whaley that's coming out this year, I think this year, on those particular campaigns in history. And so the structure of tax and budget system matters, and the way that, as I already mentioned, property tax assessments and such, if you're taking more away from folks and not investing it back in the schools in those same areas, this, again, it impacts these longer term health outcomes in so many ways, and that social determinants of health are all interacting. And I just have a link to we have a great explainer on the state budget that recently came out for those who want to understand how the budget is actually distributed in our state. Other things that people have probably heard about, of course, within the legal system, the criminal justice legal system, incarceration rates, I'm sure we'll hear more about that, can have long-term physical and mental health impacts. We know that Black men, Black communities in particular, are incarcerated at higher rates due to the history of the war on drugs and things like that. And when they're released, folks are released, they often have limited assistance, which again limits the resources that one can have in terms of getting health insurance and getting into safe housing and things like that. Additionally, various cost and process barriers limit the options someone has to even get out of that system in the first place. And transportation, just another great example that I think I mentioned last week, underfunding of NJ Transit, for example, has limited the quality of the system. It has high cancellation rates. It has delayed trains and buses, which stop people from being able to get to work. It also leads to more crowded trains and buses when a lot of them are canceled, which led to a big health hazard for COVID, and various other sanitation and safety issues. There are lots of things I'm not talking about here as far as the way occupations developed, education investment and things like that, but these are all additional things that all interact and end up impacting those health outcomes, in addition to the lack of insurance and the way that hospitals are funded. So just very quickly, how do we move forward? The question is, who does a policy impact? And that's what we focus on in NJPP and what we're trying to focus on, move forward, in that we argue that better data is needed for understanding impact across racial groups in many cases. The emergency preparedness plan for the pandemic in New Jersey hasn't fully integrated all of these different things that can put people at risk, for example, and emergency funding for climate change effects like loss of housing, even the hospital funding that came from the federal government early on in COVID is often based on revenue levels. And so that can put more money back toward wealthy communities and away from low income communities in a very unfortunately negative way. And then of course, development of more methods to incorporate all these interactions and greater representation. And I can talk in question and answer about how to actually participate in speaking to state health policy or state policies and things like that. So I will leave it there. Thank you.
Okay, thank you so much. I said at the beginning that this was a multifaceted and very, very complex issue. And I'll tell you, you did a great job in summarizing and putting that together. Really great job there. So our next panelist is going to be Emily Baggett, MPH. Mrs. Baggett joined the Trenton Health Team in February 2018 as the Senior Director of Policy and Strategy. Prior to joining the Trenton Health Team, Mrs. Baggett served in the Policy Office of Governor Chris Christie as a Senior Policy Advisor, handling policy matters related to health, human services, the child welfare system, housing, and the state's opioid-related initiatives. In addition, she spent 3 years working on health policy for the American Action Forum, a think tank in Washington, D.C. She regularly drafted white papers, data-driven infographics, and congressional testimony for the organization's president. Mrs. Baggett holds a Master of Public Health from the George Washington University with a health policy concentration, as well as a Bachelor of Arts in Political Science from the George Washington University. Welcome, Emily. We look forward to your presentation.
Thank you. I'm going to get my screen sharing up. Yeah. Hi, everyone. Thank you so much for having me. As Ms. Clark noted, my name is Emily Baggett, and I'm the Senior Director of Policy and Strategy at Trenton Health Team. So I'm sure many of you are, some may be a little bit familiar with THT, but I'm going to give a little bit of background on who we are and what we do. A quick overview of our origin story. We were started as an informal partnership of St. Francis, Capitol Health, Henry J. Austin, which is Trenton's federally qualified health center, and the City of Trenton Health and Human Services. And these 4 founding institutions came together to collaborate and work informally. And the way the story goes, the monthly meetings became biweekly meetings, which became weekly meetings, at which point they said, we need to create a body to do this work more formally. So when THT started, we were in a little space in the city's Health and Human Services building. We've now moved to our own office at 1 West State. And what you see here is a mural. It's kind of hard to capture in a photograph because it's like kind of a long, narrow hallway. But we had Leon Rainbow, who's a local graffiti artist, take our vision for a healthy Trenton and turn it into a piece of art. And so this is on our wall. And then I also have a picture up here of, it's a very old picture of our office building, but that building was recently bought and rehabbed. And so that's where we are. And so we have been a formal nonprofit for a little over 10 years now. We've grown significantly in the past few years. And just a stat we're particularly proud of is that over half of our staff are either current or former Trenton residents. So we try to recruit team members who have strong ties to the community or are, current community members. When this group of organizations started meeting and founded Trenton Health Team, they were initially very focused on stabilizing the highest risk, most clinically complex, like a population that was using the ER, continuously when, maybe because they didn't have appropriate access to primary care. Some often, in this patient population, there were other issues that healthcare is not well equipped to address, housing insecurity, persons experiencing homelessness. You are not going to get your mental health condition stabilized by going to the emergency room on a regular basis. So, when Trenton Health Team started, we were focused on kind of this tip of the iceberg, these really high need patients. Then moved into how do we improve the healthcare system to take better care of the population and our communities such that people don't rise to that level of needing to go to the emergency room 100 days a year. One of the things we did to improve healthcare in the community was developing a Trenton Health Information Exchange. So we have partners, both clinical and social service, that both send and receive data in a health information exchange. And that way, if you're seen by someone at Capitol Health, they can view your records and your labs and everything from care you got at St. Francis or from care you got from your primary care doc, and potentially even see some records from the Rescue Mission Homeless Shelter. Or we have also integrated this with a social services referral platform. So for some patients, if they were assessed by a social worker at one of our partners, those results can then also inform the clinical provider for their patients. And that also gives us a wealth of data to kind of monitor health disparities, monitor ER utilization. We could, for example, we have a project right now looking at chronic absenteeism in the schools, and we're able to see, what is the population of youth in Trenton that have had 5+ ER visits for asthma complications. So we get really interesting population health data from that HIE, and it also improves clinical practice by giving clinicians a full picture of their patient's health. We've also then gone even further, sort of sometimes this is called like going downstream, going upstream. How do we make the healthy choice easier for our community? A lot of this relates to the social determinants of health that Brittany mentioned. What's going on in your neighborhood? What's going on in your community? Where are your options for food access? I have an example on this slide. We had a project supporting breastfeeding and did breastfeeding education. And as part of that, we installed one of these lactation pods in the Trenton Public Library. Just like, how do we, support breastfeeding? Let's make it the easy choice. Let's make sure there are places and spaces where that's welcome. We also realized that, a lot of the policies that influence systemic racism, that influence disinvestment in urban communities, that influence public safety, education, all of that is going to have an influence on the health and well-being of our community. And so, this is overly simplistic, but I see, policy really influences all of these types of things. But certainly, how do we set up community conditions? So one of the things that Trenton Health Team works on, or one of the ways that we work, is by being a regional health hub. And this is something that grew out of a demonstration project we did with the Medicaid division, which is within the New Jersey Department of Human Services. For a variety of reasons that would probably bore everyone to tears, we did not turn into an ACO. That's sort of a specific thing in healthcare. So we worked with the state legislature and Medicaid to give us a better framework to describe and formalize the work that we do. So Trenton Health Team was one of the 4 first regional health hubs in New Jersey. And so we started working on this really in 2018, changing the name from ACO to Regional Health Hub in 2019. And then we got the legislation introduced, and it was passed and signed in the beginning of 2020. And we saw the potential for state agencies to use the regional health hubs as they're designing programs and as they're trying to evaluate their services, and that we could really be a voice for our communities, both community members and then also clinical providers, social service providers, and partner with state agencies on how do we make this whole system work better and get to our goals of better health outcomes, reduced health disparities, and when we designed this, we had no idea that there was a global pandemic coming and that we would be called on by state agencies in just an unbelievable way. So, throughout this pandemic, if I were just to say off the top of my head, I mean, we talked to the Department of Health probably weekly. We've talked to Human Services, we talked to Medicaid, we've talked to the Department of Labor. I'll give an example on the next slide. We've talked to the First Lady's office around what's going on with maternal health. We've talked to the Office of Civil Rights. And so, how can we share these on the ground learnings that we are getting both from our staff who are doing programs, but also from all of our partners? Trenton Health Team convenes at the beginning of the pandemic, it was a weekly, 7 days a week call every morning. The hospitals, the city, the FQHC, now we have the county and the schools. What are the rates looking like? Where are the testing sites? Where do we need more testing? Right now we're trying to help the system coordinate around who has vaccine and where are we not getting? And, so as a kind of hub for that work locally, we can then take those learnings and direct them up towards the state. So, when I came on at THT, I think we anticipated joining other policy advocacy coalitions and doing advocacy and doing some policy education around those big policies that influence social determinants of health. And where we've actually found a more appropriate lane for a community-based organization like THT is influencing sort of around the margins and the small policies that nobody else would be worrying about or thinking about or talking about. So I will give a few examples just to share what I'm talking about. So this COVID-19 testing and job worries. This is a flyer that the Department of Labor and the Department of Division of Civil Rights, which I think is in the Attorney General's office, put together. And this came about from a request that THT made. And this actually started with a story we heard from one of our clinical partners. And their call center got a call from someone who was seeking a COVID test and, had the classic COVID symptoms: fever, short of breath, coughing, loss of, couldn't smell or taste. And as the call center is engaging this person and trying to schedule the appointment, they're hearing beep, beep. And the person said, where are you right now? And this individual who was symptomatic was at, I believe it was a female, was at her job checking out groceries because her manager would not let her call out without proof of a COVID positive test. So thankfully they mobilized, they talked to the manager or faxed, the note or whatever it was. But this was, that's a really dramatic example, obviously, but we were hearing that people didn't want to go get tested because they would have to stay home from work, or they didn't want to, sometimes they just didn't want to know, even if they had a symptom, because they were worried about their job, or they would worry that they would get laid off if they had to call out. So we said, we need to arm our community with information about, their job protections, and we need to arm people in clinical settings about what are these different ways that people are protected, because they're calling and they're sharing these concerns at the testing site or at the, call center for the FQHC or wherever. So, it's like, I think I laughed because I was like, maybe you guys could just throw together like some bullets on, ways that people are protected. And obviously it's so complicated depending on whether your employer qualifies for this or that, and whether you would qualify for paid leave or different things. But the state put together this sheet in English and Spanish that we could then help disseminate in the community. this other picture down here, this was the Mercer County testing process. Back in the spring, they set up a test site that was a drive-through workflow at Quaker Bridge Mall, right off Route 1 in Mercer County. Trenton Health Team used our health information exchange to be like the scheduling service and help with that workflow. And we said, we're partnering on this, and we expect once you get the Quaker Bridge site open that the next priority is walk-up sites in the city of Trenton that rotate around the wards so that people who don't have access to a vehicle can have access to testing. And so this is one of these. They use they use Henry J. Austin's mobile health clinic to like change in and out of PPE and have the administrative stuff, but all the testing was done outside, as you can see here. Another example of something where, again, like not a big policy, legislation, or regulation change that we're seeking, but we have the SEED program, the Cancer Education and Early Detection Program for the county. Our nurse practitioner was doing cervical cancer screenings on uninsured women. These happen to be mostly women of color, and finding women who were either expressing concern about sexually transmitted infections, or she was seeing evidence of an STI. And because the SEED program has a certain funding source and you can only do it for cancer screenings, she wasn't able to serve those patients' need for that testing. So we haven't been successful with this yet, but we've asked the Department of Health, like, could you pilot something with us where we're able to offer STI testing in addition to cervical cancer testing when we're already with a patient, already serving a patient? And that's just one very small example, but the sorts of things that fuel the health disparities, that there's access, but it's not full access. It's not the same access that someone with private insurance who could say, you know what, I'm also interested in being tested for this or addressing this issue while I'm here. And right now we're very involved in trying to help the state and DOH make the vaccine situation more equitable. I think this is, Brittany mentioned policies that have a disparate racial impact in practice, even if they don't have that intention. State agencies came to THT and the other regional health hubs last fall, and with sort of how do we make this vaccine rollout equitable? And we had ideas. And ultimately, we are in a system right now where you are very disadvantaged if you don't have digital access, if you don't have the opportunity to sit at a computer and refresh your screen over and over again until an appointment pops up, and if you don't have transportation to one of the sites, because you may or may not get an appointment nearby. So we are advocating very strongly for our community, for the state to send more doses to the federally qualified health centers, to reserve certain doses for older populations, to have certain appointments that the call center can actually schedule for people if they don't have access to an email. We're helping community health workers understand the system so that they can help their clients and patients. So that's just kind of a smattering of the types of things that are like little p policy rather than bigger, but where we can really advocate for our community. So I will stop there. Thank you.
Thank you, Emily. Thank you for presenting that robust, on the ground, comprehensive program. It lets us know that there are things that are working and can be done. All right, our next panelist is Kenyon Farrow. And Mr. Kenyon Farrow is an award-winning writer, activist, and strategist. He has worked on local, national, and global campaigns on issues related to criminalization and mass imprisonment, homelessness, health justice, and LGBT rights. He is currently the co-executive director of Partners for Dignity and Rights, a national organization that partners with communities to build a broad movement for economic and social rights in the areas of health, housing, education, and work with dignity. Previously, he served as senior editor with TheBody.com and TheBodyPro.com, and currently serves on the board of the NY Transgender Advocacy Group, Prep for All, and Global Black Gay Men Connect. In addition to his political work, Mr. Farrow is an essayist and author addressing difficult topics in race, inequality, healthcare, and sexuality. He is the co-editor of the book Letters from Young Activists, Today's Rebels Speak Out. His work has appeared in many anthologies, publications, and websites. He has a bachelor's degree in theater from Ohio Wesleyan University and studied at the University of New York School of Journalism. Welcome, Kenyon.
Thank you very much for the invitation, and I will also share my screen now. And I'm gonna take the discussion kind of to a more sort of 50,000-foot view to discuss kind of race, class, and the media's discourse on healthcare policy. So, which I think is important to think about in this conversation, because you know, the media often helps us, or for better or for worse, understand, you know, the kind of contours of healthcare policy, what's possible, what gets defined as popular, or what the even policy prescriptions or issues are. And so I think it's important for us to think both about the impacts of actual policy, but often how policy gets shaped and whether people understand that policy is very much shaped by media. And as you know, somebody who's worked both as you know, kind of in social justice, you know, movement organizations, but also as a journalist, I often think about the interplay between these the sort of media and public policy as it pertains to healthcare and public health writ large. So where we are now, when my colleague Ben Palmquist, who is will be presenting after me, we first created this slide. We were at 400,000 deaths from COVID, and we are now at 528, I think, at the last time I looked at the television. So you know, it's like hard to even keep up with the slide, given the kind of colossal disaster of a pandemic this has been. But some other kind of headlines from the current moment: over half of Americans have delayed or don't get healthcare because they can't afford it. And a survey from the Commonwealth Fund, which we're probably also very familiar with, 79 million Americans have problems with medical bills or debt. Now, I know some of the slides I'm going to show are a little, you know, horrifying to look at given their kind of racist depictions, but I think it's important for us to kind of understand the history of where we're coming from when we think about both healthcare and kind of social policy, which interplay with one another, right? We, you know, we're here talking about healthcare, but as Brittany's just, you know, other panelists have been pointing out, you know, when we talk about housing and, you know, everything from food stamps and welfare, the whole sort of network of the social safety net, including, you know, publicly financed healthcare, are influenced very heavily by race in this country. And so if you think about some of the narratives about, you know, what it means for the government to provide for, you know, its citizens, you can see in this cartoon here, the idea of, you know, kind of who's deserving of you know, access to to public benefits, you know, and this goes back to 1866, you know, talking about sort of, you know, Black people, or, you know, Negroes in the old parlance, as idle and sucking up public benefits through the Freedmen's Bureau, right? Not to, you know, discuss the, you know, kind of reparations and frankly, what was owed to Black people, right? But instead is being framed as Black people kind of taking and mooching off of the state. And obviously, I think many of us who've lived through the last 40 years know that this language has really not gone anywhere. Moving forward into the 20th century, at this example of the American Medical Association, who I, often, think in our kind of, political context are often thought of as, it's obviously the association that most physicians in the country belong to. And think of them as sort of apolitical and as, kind of purveyors of, modern, healthcare in the United States. But they've also been very active over the course of their history in blocking, public policy around, sort of publicly funded healthcare, whether Medicare or Medicaid, et cetera. And so this here is a, blueprint of the campaign against what they called compulsory health insurance at the national, state, and county levels, right? It's more examples of this from 1949, the AMA. Voluntary, so it's this idea of socialized medicine, right? So we heard that language in the debate about the Affordable Care Act and the, efforts to overturn it during the Trump era. But we see that language goes way back, right? To this is the 1940s. We've been talking about socialized medicine, as a frame that the right has pushed. Again, through the AMA, right, which again is a political organization and not just an above the fray association of doctors. Again, 1943 to 1946, more political cartoons talking about compulsive collectivism, so tying the kind of red baiting and kind of anti-communism scares to, fights for universal health coverage. Again, more the taxes, as a frame, right? Taxes, stealing your hard-earned money to pay for, undeserving people, right? So, seeing that language, right, again, from the 1940s, which is something that we still hear, kind of the right wing talk about and, makes its way into how, media covers issues, right? Framing it as bureaucracy, right? And, as like, the government getting in the way of your relationship with your doctor, right? How many times have we heard that in the last 10 years? That language and that framing going back again, the AMA's, work in the 1940s to thwart what was then one of the proposals to create a kind of universal healthcare single payer system in the United States. So, these efforts go a long way. Again, the kind of red baiting and tying social, kind of publicly funded healthcare to communism, right? In the height of the post-World War II, kind of Red Scare and the Cold War, beginnings of the Cold War, same thing. Right. So here we see actually the ways in which, and I don't think we talk about enough as a country, the ways in which the civil rights movement actually is partially responsible for helping to push for Medicare and Medicaid as we currently know them in the United States in the 1960s. And so one of the dynamics here was that it was understood by civil rights activists that healthcare and, hospitals, of course, in the South were segregated spaces. And passing the kind of amendments to the Social Security Act in 1965, which create Medicare and Medicaid, would also mean that the federal government had some leverage to desegregate or force hospitals in the South to desegregate if they were going to get, money for, through the amended Social Security Act in 1965. So here you see civil rights activists demonstrating against the American Medical Association as a Jim Crow sponsoring organization. Right. So we see the way in which like the kind of development of the new right, after the, kind of New Deal and war on poverty programs that were created, through FDR and LBJ in the 60s, to the ways in which kind of race continues to sort of foreground itself in social policy, including healthcare policy in the 70s and 80s, right? So many of us are familiar with Ronald Reagan's 1976 run, where he really sort of framed the kind of welfare queen, and so you see this quote, which is where that phrase comes from. In Chicago, they found a woman who holds 80 names, 30 addresses, 15 telephone numbers to collect food stamps and Social Security veterans benefits, right? All of this, her tax-free cash income alone has been running at $150,000 a year, right? So that was a famous kind of welfare queen speech, right? Which posited that like spending, federal funds on, welfare, food stamps, and health, publicly funded healthcare was really just being given to scammers, right? And particularly Black women, in that way. Now, if you go to the top quote, you see this conversation. These also leaked in the last few years, or tapes of some of these conversations from both the Nixon administration, is talking about taking, the kind of specific race language, so taking the N-word out of their sort of public messaging and talking about, forced busing, states' rights, right? All these taxes, right, as a way to kind of promote racist public policy and social policy and healthcare, but not using actual racist language to do so, right, which we are still living with. So more contemporary, right? What does, government symbolize? So this is how, in a way, we have come to the point in which we continue to have these sorts of frames when we think about healthcare and social policy. So bureaucratic blob, it's an imposition on freedom, right? To, mandate individual healthcare, et cetera, right? Like those sort of things. Taxes are theft, right? It's anti-American, right? To create mask mandates, right? In a respiratory, contracted pandemic, right? Also talking about people in need of healthcare as quote unquote consumers, right? So really creating like this sort of business language around the relationship between people in need of care or patients, right? As like quote unquote consumers, right? And handouts to the people. So some of this research here, looking at how Americans, going back to the 1990s of the, kind of the President Bill Clinton's initial push for really transforming the publicly funded healthcare in the United States and healthcare policy writ large. We get to, after many decades of again this kind of language being pushed by the right, as we just went through, the ways in which people begin to use these sort of like think tanks and kind of messaging operations to do focus groups to create the kind of messaging to thwart, changes to the healthcare system, right? So, government-run health insurance plan, right? So you see the ways in which, like, focus groups responded to certain language, right? In the ways in which these think tanks were looking for the ways in which to talk about these things publicly to create a public disincentive for changing public policy in healthcare. Right. So, some of those things. So sorry, I'm trying to move us along really quickly. So by the time we get to the Affordable Care Act changes in 2009, you see this, email to Fox News reporters and how they're supposed to talk about healthcare, while they're on the air. Right. So not talking about the public option that was part of the ACA proposal as a public option, but to use the qualifiers, the so-called public option, to talk about the government-run plan, right? Like, so all those things. And because, again, going back to the 1970s at least and before, ways in which public became racialized, right, as Black, right, or and people undeserving, right? So they could go to this language about government run that brought together all of these ideas about race, about socialism, about, et cetera, and just using the phrase government run. Some of the Heritage Foundation, Cato, Freedom Works, some of the think tanks involved in that push against the Bill Clinton, and obviously, Hillary Clinton was actively involved in this campaign as well to change healthcare policy. Some of the folks. So again, here you see some of the recent messages in the last, 10 years about how people on the right talk about healthcare, as pundits, the arguments against Democrats. Healthcare plan must center around politicians, bureaucrats in Washington. You get a fine if you that you have to put in the jar on the table if you just say public plan instead of government plan. So right, Senator John Cornyn even pushing for people to almost like swear words. If you call it a public option or a public plan, you will we'll fine you as if you're a 12-year-old using curse words. So then if we look at this slide showing the ways in which government healthcare, government-run health began to be used, and you see the sort of slight uptick in the early 1990s, which is when the Clinton plan was being discussed and debated. But then you see this huge surge in 2009, right, which is when the Affordable Care Act was being debated. And so you see these, the ways in which, that language really grew over time, and the way in which it was picked up by the media. So, which is to say that, the right really being strategic about testing this language, et cetera, didn't just impact how individual people responded, but they actually were able to influence the way journalists across the board, not just Fox News, but across the board, talked about these programs, which influenced how people saw them, right? All of these different media organizations across the political spectrum have kind of played a role in kind of furthering some of that language and framework. Before I turn it over to back to the moderator to introduce Ben, I just want to point you to a report from 2019 that Ben Palmquist with us at Partners Dignity and Rights developed, really analyzing this issue, how the media, called Parroting the Right, how the media and polling company adoption of insurance industry spin warps democracy. And you can find that report at this link. And thank you.
Kenyon, that was really eye-opening and enlightening. Thank you so much. Fabulous, fabulous. Okay, and our final panelist and fourth is Ben Palmquist, MA. Mr. Ben Palmquist supports grassroots campaigns for universal publicly financed healthcare and the new social contract project at Partners for Dignity and Rights. Before joining Partners for Dignity and Rights, he planned a conference on grassroots community organizing, conducted worker-led labor research, supported community development organizations, and ran an international volunteer program, a fellowship program for youth, young people of color, and a day camp. He has worked with many social justice organizations in the United States and abroad. Mr. Palmquist has published work in These Times, Jacobin, the Journal of Law, Medicine, and Ethics, Nonprofit Quarterly, and The Progressive. I think he has a pretty big article in the Journal of Law, Medicine, and Ethics now. Ben holds a Master's of Urban and Regional Planning from UCLA and a BA in Urban Studies from Stanford University. Welcome, Ben. I see Ben. Not sure why we're not
Can't
hearing
hear
Ben.
him. Yeah.
We really want to hear you, Ben.
Can you hear me?
Yes, loud and clear.
Sorry. So I know we only have about 5 minutes. So I'm going to do my best to be really quick here. Just to say a word, Kenyon and I work for Partners for Dignity and Rights. So we're a national support organization for grassroots human rights movements around the country. So we work with young Black and Brown people who are being criminalized and pushed out of school to support them in shifting to, toward restorative justice practices in education. With farm workers and workers in other low-wage industries who are working to develop worker-led enforcement practices and in housing, healthcare, and other issues as well. And so one of the things that's really come up from our grassroots partners across the country is that people are feeling in all sorts of areas of life really sort of systematically disempowered from being able to make decisions. I feel this in my life, and I think for the closer, sort of the further on the margins you are, the poorer you are, the more racialized you are, and so forth, the more this impacts people. And so on an individual level, it's things like, you know, not having the security of knowing if we're going to be able to pay the bills next month, or knowing if we're going to be able to get that healthcare treatment. And it happens, of course, on a collective level too. And so on a community level, Black communities, immigrant communities, Native communities, and others are just systematically sort of deprived of the actual decision-making ability to say, what kind of schools do we want? What kind of housing do we want? What kind of how do we want to meet our basic needs and do that together? And so there's, if the problem is partly rooted in sort of the lack of being able to have actual autonomy and decision-making power, then sort of our policy solutions, in part in order to advance health justice and racial justice, need to be changing actually who holds decision-making power in policymaking and in policy implementation. And so there's different ways to do that, right? There's no one, all the problems we've been talking about today are sort of so widespread that it can be a bit overwhelming, but I think part of the silver lining of that is that there's a lot of different pathways that we can move forward to advance justice and make sure that people's health needs are being met. And so there's ways to open up sort of public decision-making to make more space for people as members of the public to have more power, to really shift power away from, say, insurance companies being able to deny care, or drug companies being able to price people out of care, or hospital companies, real estate developers and landlords, employers. They all just hold a lot of power over our lives. And so there's ways we can bring the public in through, for example, participatory budgeting and other more participatory processes, so that absolutely elections are important. Like, we need to be organizing through sort of the representative political system, but I think we need more space outside of that too, for us to really be able, as both individuals, but also as communities, to be able to advance our health needs. And so local public health departments, and on a state level too, in New Jersey and elsewhere, I think there's a lot of opportunity for them to, have public hearings, but in a way that's really accessible to working people, to parents who are caring for kids and who might need childcare, to people who don't have transportation, to people who have disabilities and have a hard time getting to somewhere physically. And so there's ways to really open up governance in a really ongoing way to make sure that communities are for themselves able to say, here's what our priorities are, here's what we need. And then over time to be able to monitor and enforce the decisions that get made to make sure that they're able to hold both government and private actors to account. But the other thing is that we don't exist in society just as individuals, of course. We are members of communities. And so I think there's also a really important role to figure out how can we build in ways for groups like the Sankofa Collaborative or others to who are really representing communities, and especially Black, Native, Indigenous, immigrant, and even within those communities, right? Like Black trans women, or undocumented workers on farms, or these sort of different sub-communities whose health needs are most frequently denied and most acutely denied, to say, okay, are there ways we can actually structure policy and governance so that farm worker organizations have a role in labor enforcement, or such that parents and teachers and students have a much greater control in schools about what their education actually looks like, and where the where public money is going. So there's sort of a broad set of possibilities there, and I know we have to sign off, so I will end there. But I hope that adds a bit of a hopeful note too to that. There's a lot of challenges which are very real, but I think there's a lot of opportunity, and it's really but this isn't going to sort of happen automatically, right? It's sort of up to us to come together in the way that you're organizing this webinar to try to actually push to assert our power and make things happen.
And those were some great and powerful statements, because my big question to start off was going to be, have community-based organizations and individuals really played enough of a role, and how can we advocate? And you answered that very succinctly. Thank you for those suggestions. I'm not sure, Michelle, if we have questions, but while we're taking a look, you know, Ben, I'll start with you. Do you think that CBOs have played as much a role? How can we get individuals more organized? Because I hear what you're saying about, you know, there should be more open government and so forth. And, you know, sometimes I see the same faces sitting on these panels that are supposed to be giving public input, but I'm not so sure we have, you know, comprehensive group of people.
Yeah, it's a lot of work. And so I do think, you know, having a real attention to race and gender and other sort of identities is really important to make sure that we're finding representative people to speak for themselves rather than being sort of spoken for. And similarly, I do think that it's you know, those of us who are lucky enough to be paid professionals in this kind of work, I think do have an important role, but we need to be trying to find ways to bring in everyday people who are really directly impacted to speak for themselves and to actually hopefully wield political power. So I guess there is not one way to do it, but for us to try to find ways to connect up with other groups that are doing organizing and base building, you know, or organizing whether in a workplace or on a community level, and try to figure out where can we come together, where do we have sort of shared visions and goals and stuff, and how can we collaborate to actually hopefully wield power in Trenton and elsewhere.
Thank you so much. Michelle, I'm not sure if we had questions from the audience. I didn't want to leave them out. If we don't, I think that Ben's comments were would be an excellent way to end with what we can do. Often these conferences describe problems and not what we can do, and I think we've done a good job of talking about actions.
That's it. I don't see any questions in the chat box, so I think we're good.
Okay, I think because it's 2:30, I have a page of questions, but I think we're at our end point, and this was a fabulous panel. I can't think of any way we could have addressed this issue any better. Thank you so much, and thank you, Sankofa, for what you're doing. This is really important business.
Thank you all so much.
Thank you.
Thank you, everybody.
Thank you.
You panelists.
I would like to also thank you, Karen,
Yes,
for being with us and doing such a wonderful job this afternoon. And I'd like to, of course, thank our panelists. I had to step away for a bit, but I did catch parts of each one of you, and we could not have asked for a better team. You were knowledgeable, you were sensitive to your audience, you knew who you were talking to, and framed your remarks in a way that we could understand. And I just really appreciate your coming and answering the call from the Sankofa Collaborative. Thank you so much. And thank you to the Sankofa Collaborative team for doing what you always do so well and putting our programs together. We thank you. And we ask that all of you join us again, same time next week for our third and final panel. And to look on the Sankofa website for other programs that we are offering. I know off the top of my head, we have 3 upcoming events. I'm afraid I'm going to make a mistake if I give you particulars, so I won't. But remember, April 29th, that's the next one. So after our panel on health next week. So thank you all so very much.
Yes, and Sam,
yes.
and Michelle Hickey, we could not have done this without you.
Well, thank you all, and stay tuned for, as Linda said, our next panel and for future programs.
Fabulous.